Hi, everyone. Welcome. My name is Barbara Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, and you are here for the third in our Geriatric Healthcare Lecture Series. This winter term, the focus this term is on Alzheimer's disease and related dementias. Just want to remind you that you should connect with your site coordinator if you're looking for handouts, evaluation sheets, sign-up sheets, or information about continuing education. And please, if you haven't yet, fill out a profile form. We do need those to be able to report the number of people attending these lectures to our funding agency, which will allow us to continue to offer these lectures each time. I'm really happy today to introduce to you Piruz Huda. Huda has worked as a psych nurse practitioner since 2001, with the majority of his treating population being older adults. He co-authored an evidence-based dementia care training program with Dr. Linda Terry from the School of Nursing and has made dementia a key factor in his daily clinical practice. Currently, he provides psychiatric assessments, medication management, and consulting to 15 assisted livings in the Seattle area. He is much in demand. He's also a clinical instructor at Pacific Lutheran University with an emphasis on geriatric psychiatry content. And he's going to talk with you today about treatment of behavioral and psychological symptoms of dementia. Welcome, Huda.
Thank you. Happy to be here. I want to apologize in advance. I got a little bit of a virus, I think, going on, so I don't have my full energy today. So I'm sitting down. Trying to move the slides here.
Right arrow key.
None of them are working. Okay. All right. Not much to disclose. I currently go out to a bunch of, like as we said, I go out to assisted livings, Aegis Living, and Horizon House, and the views and opinions are basically my own. Topic to cover today is I'm going to talk about what to do about problem behaviors, and often from a behavioral management perspective. I'm going to outline why we should be prioritizing non-pharmacological interventions. I'm going to describe the non-pharmacological intervention I'll be focusing on is behavior management. And I'll describe the key components to behavior management, which involve realistic expectations, communications, and the ABCs, as well as pleasant events. I'm going to talk about how we can implement this training model into the DICE approach, which is an approach developed by geriatric psychiatrists for dealing with working with patients and their dementia patients and the caregivers and family members who work with them. I'll talk then briefly about the limits of pharmacological interventions for BPSD and how we would integrate pharmacological and non-pharmacological interventions and discussion of this and implementation in the clinical practice setting. Now, I'm going to skip ahead to this slide here. This slide right here is talking about, I get the impression that we have a lot of, this is supposed to be a practical discussion about ways to implement behavior management in the clinical practice setting. So persons who are working in a clinical primary care office, internal medicine office, but then the other setting where I think a lot of people are treating people with dementia might be in the residential setting, adult family homes, assisted living facilities, long-term care such as nursing homes, right? And so you guys already had a couple lectures on dementia. What we're going to be talking about today is what I'm laying out on this slide as presenting problems. The chief complaint of what's brought in, it's not the cognitive symptoms. I'm talking about targeting here. The cognitive symptoms, remember, is the effects on the brain that result in short-term memory deficits, complex attention, executive function deficits, language. These are irreversible. This is part of dementia, all right? What brings patients in with complaints, right? What is the presenting problem? The problem that you might have, a patient coming into your office might be a bevy of what we call neuropsych symptoms, neuropsychiatric symptoms related to dementia. And these are just a bevy, what we can describe them as depression, psychosis, agitation, aggression, apathy. But the rubber hits the road with what are you hearing is the problem. It could be problems such as, I'm going to lay out some examples and we'll come back and talk to it. I don't like going in depth on a single case, because when it comes to dementia, you've seen one person with dementia, you've seen one person with dementia. It's so different. And I tell you, now that I'm just exclusively working with cognitive impairment patients, no two are alike, and the presenting problems are not always alike, and how they respond to treatment are not alike. So, for example, I might have an 80-year-old patient referred, might be coming in the door. She's been crying a lot. She cries at night. She can't go to sleep due to her crying. It could be an 89-year-old who is not feeling safe at her assisted living. She thinks she's all of a sudden saying this just happened last week. I have a patient telling me who her daughter's her main care, visits her constantly, and they have a wonderful relation. Then she's convinced that her daughter is trying to kill her. Her daughter's working with a pimp who is another resident that lives downstairs, and how they're plotting to kill her. And what do you do about these sort of situations? What do you do when you have another case might be a patient who won't sit still. She paces all the time. What do you do about the patient who is fine during the day? She knows she's living with her daughter in the house on Green Lake, but in the evening hours, she is convinced, she's restless, she needs to go home. She needs to go home, but the home isn't even her house that used to be in North Seattle. Her house is in California that she needs to get to. How do you solve this, right? What do you do about the patient that refuses to take their medicines, right? I don't need to take medicines. Well, how are we going to treat their blood pressure? How are we going to, this is a basic health hazard if they're not going to take their medicines. But this is a problem that you will come into your office, right? And you might have somebody who's impulsive. You might have a patient who is agitated, quickly angered, might be impulsive in punching people. These are severe issues and these are safety issues, but these are the problems that walk in the door, right? And the question is, what are we going to do about these? Because these are the problems of dementia that we have to mitigate. When you get right down to it, to step back, when I'm talking about what I'm trying to do, we are treating an irreversible condition here. That is, it's a disease process that's, like a slow train moving down the tracks. It's slowly going to get worse in these cognitive symptoms, right? The ones above, we can't do anything about that. What I'm trying to do as a psychiatric nurse practitioner, and I want to, motivate you guys to think about, how can I, even though this is this chronic condition that will only worsen, how can I improve a patient's quality of life? How do I relieve their distress? How can I make their life better? And of course, that's going to be by reducing these neuropsych symptoms, right? So we have these symptoms. What are we going to use? Are we going to use medicines or non-medicines, right? Well, when it comes to put it right off the bat, one article I'll be referencing is the article by Kales called DICE, D-I-C-E, which is an approach I'll be talking about a little bit later, where they indicate what doesn't work for medicines. Trying to use medications to treat these behaviors or symptoms of unfriendliness, poor self-care, memory problems, not paying attention, repetitive questions, refusing care. The person refuses to take a shower. There is no medicine that's going to make that patient say, oh yeah, I guess I do want to take a shower. There is none of that, all right? The person that says, what do I do now? And then you tell them they're doing fine. And then 20 seconds later, they forget and they say, hey, what am I supposed to do now? No, we don't have a medicine to fix that, okay? And certainly on the right, CMS, Medicare indicates, yeah, you can't use antipsychotics for the behaviors of refusing care, fidgeting, mild anxiety, memory problems, sadness, or just being uncooperative. And I say that because you will get referred patients that says they are not cooperative with treatment. They're not letting us to do personal cares and these sort of things. Well, that alone isn't something you want to throw a medication at. Now I'm backing up here. So I'm already saying not medicines, okay? I'm saying, what I'm saying is, as a psychiatric provider, we have to emphasize the non-pharmacological interventions. When I look at journals, when I go to geropsych conferences, they indicate it's almost, when they're talking about the disease process and treatments, it's always kind of given short shrift. But oh yeah, guys, they will say, and of course, non-pharmacological interventions, the number one is the first line treatment, and they just leave it at that. And you're like, but what do you mean by non-pharmacological interventions? And what I'll be talking about are behavioral treatment, behavioral interventions. But I just want to also give credence to non-pharmacological interventions, or of course, anything that's not a medication, right? So on my next slide, there's an article by Abraha that I'm referencing here from 2017, identifying what various non-pharmacological types of interventions for targeting dementia-related behavior disturbances. The first type, they group them up into 4 types. Sensory stimulation, this could be acupuncture, aromatherapy, massage, light therapy, cognitive stimulation, music, singing, dance, activities such as that. I will say there is huge growth potential when you get right down to it. Think about the more interactive computer software-based programs such as Alexa, right? Something interactive that can help keep people stimulated and activated throughout their day. There's other cognitive emotional oriented interventions. This could be anything from validation therapy, reminiscent therapy, various intervention groups that keep people stimulated. And these are, it's not, I'm suggesting one or the other. These, of course, are part of, when I think of the programming that might be in an assisted living or adult family home, places where there are people with cognitive impairment, it's paramount that there are activities and things to keep people intellectually and emotionally stimulated. Then, of course, behavioral management techniques, what I'll be talking about. And then, of course, there are other interventions we could be working with to help people with dementia. Exercise therapy, pet therapy. Abraha indicated music therapy and behavior management. They did a large meta-analysis of many random treatment interventions and said that there's most evidence for the most evidence supports music therapy and behavior management as effective interventions. And when it comes to, so I'll be talking about what is behavior management, okay? Behavior management is just, it's really the psychological school of thought as it's talking about, hey, we're not talking about what people are thinking about. We are talking strictly about what they do. And I'll be implementing an approach. I'll be talking about the use of basically identifying behaviors, what triggers these behaviors, and what are the consequences of these behaviors. American Psychiatric Association, when they identify what are the key factors of behavior management that we want family members or caregivers to be able to appreciate when it comes to dementia. This is basically our objectives. What do we want when we have a patient with dementia? We want the caregivers, whether they be in a facility or at home, they are vulnerable individuals. They need people to direct their care. We want them to know that, one, you got to keep how to keep requests and demands simple, right? 2, avoid confrontation, defer requests. The patient becomes angered. 3, remain calm, firm, and supportive. 4, we want them to be, we want the overall situation to be consistent, avoid unnecessary change. We want to provide frequent reminders, and we want them to recognize declines in capacity. So the thing is, how do we implement this, right? We have these goals. How do we make this into a package for patients to utilize? When it comes to Abraha, in that prior article, actually did reference a study that I was involved with. It was the STAR Dementia Care Training Program, which is part of, at University of Washington, Dr. Linda Terry, who, I'll tell you, this was one of the best things for my career, has got to be when I was in grad school. I fell into an opportunity to be a research assistant on this project, this research grant by the Alzheimer's Association. We're working on developing this dementia care training program. And we developed a training program. And when it comes to what are the key components, what makes up a good training program? Based on our outcomes, if you look at the graph here, you just have a couple bar graphs here, blue and orange. What they're basically indicating is the control group before and at pre-test and post-test. Basically, the pre-test on the left side, you're basically measuring neuropsych symptoms, the target behaviors. They went down after the intervention, and the control group on the right, their behaviors increased after the intervention, indicating that if you train the staff to work effectively with residents with dementia, you can reduce their depression and anxiety levels, reduce those depression and anxiety scores by effectively targeting behavior management. Okay, what are the components of this behavioral treatment? Okay, the key components are whenever we do a training. Now, to step back, how long is this training? How do we do this intervention? Okay, this training program was for caregivers that work in assisted living. It was 2 days of 2 6-hour blocks of training, and then one-on-one with the staff. Okay, it's for like assisted living staff, so the staff are fully abreast of everything we practice, and implement a behavior training program for them to apply to the residents. Of course, this is, we're talking about 10, 12 hours of training, all right? If I can get on a high horse, I'll say right now, we do not have dementia behavior management as a standard sort of protocol, it seems, for people with for caregivers with dementia. It seems to me, I like to think of dementia almost as a condition like diabetes. Maybe 30, 50 years ago, 30 years ago, if you had diabetes, you get all your diabetes instruction from your doctor. Your doctor would say, you got to stop eating the sweets. This is your insulin, manage your, keep walking, give yourself insulin, boom. That's your diabetes education is coming from your doctor, right? One-on-one provider. Then they said, the patient really needs to know a lot more information, a lot more than the doctor can provide, right? What do? We send them to the diabetes education specialists, right? And they take classes, right? They have classes and they learn about their disease and the best ways to manage. It takes time, it takes hours, and it takes clinical expertise to implement this. But we do not do this. This is not standard practice. Somewhere along the line, it'd be nice if it was done, but right now it's falling on us as providers to implement behavior management. All right. And the problem is we're all medical providers and we just want to fix things and we want to treat diabetes and lower their blood sugars, right? And have a concrete, finite thing of fixing and addressing a chronic condition. But that's not how we fix dementia. We can't fix dementia. And our implementation isn't just the needle or the food. Our implementation is coaching a caregiver how to properly work with somebody with dementia. Because the person with dementia cannot learn new information, right? So I want to talk about how do we implement this? Okay, so what basically these key concepts of behavior management involve realistic expectations, ABCs, communication, pleasant events. 1, realistic expectations, that's basically what it sounds like. It's a basic information about dementia. And when you're talking to family members, we're talking to caregivers, the peers with, you don't want to overcomplicate things. We just basically say, like, if it's vascular dementia, Lewy body dementia, Alzheimer's disease, basically it's a progressing decline and people are unlearning information, right? We're going to talk about this as a disease process, about the brain changing, that people will have the decline in state, right? We talk about the stages, early, middle, late. On my handout, at the end of my slides, I have a handout that that have examples of some handouts that I use for patients, for family members to look through, which talk about the stages, what's normal aging versus dementia, right? So then I talk about using the ABCs. How do you implement the ABCs and what are they? The ABCs are identifying what is a problem behavior, which is the B, ABC, activator, behavior, consequence. Now, what it comes down to it is it sounds simple. A leads to B leads to C, and there's also an arrow C going back to B, okay? This is basically indicating there is a behavior. What you need to do about a behavior we want to identify and change, what can we do? The behavior does, okay, we're basically saying the behavior does not occur in a vacuum. There's something that's triggering or activating the behavior. And after the behavior, there's something that's reinforcing it and having an impact on whether that behavior again is the consequence. All right? The way we implement this is we think about this. All right? Here's an example. A resident, a patient, I keep on saying resident because I go out to assisted livings. All right? We got our patient with dementia who it's 2 p.m. in the afternoon. The caregiver says, hey, Doris, here's your evening medicines. You need to take these. And Doris says, no, I don't want to take my medicines. Okay. All right. And then the caregiver says, Doris, you really need to take these medicines. She says, I don't want to take any medicines. I don't know what those medicines are. The doctor says you need to take them. I don't think, and then they start getting agitated. All right. She starts getting upset. You keep on pushing the medicines. It's like, you really need to take the medicines. I'm not taking the medicines. The patient gets upset, smacks the medications aside. Okay. So what is the problem behavior? All right. So in other words, okay, it could be that the resident's upset, the resident is angry, all these things. But the question that the behavior is, what did the resident do? What did the patient do? What was the problem behavior? Well, the problem behavior is she refused her medicines. Okay. And then, what I'm always coaching their family members and caregivers to identify, tell me more, be as specific as possible. What was the person doing? She refused the medicine. Where was this happening? This was happening in her apartment. Who was present? The caregiver and the resident. Patient. When was this happening? This was happening at 2 p.m. See, we identified all this. Then we asked A, what happened just before she refused the medicine, right? Well, the A was the caregiver came in and said, Doris, you need to take these medicines. And the resident said no. Okay, we got A and B. C, what happened after she refused? Well, the caregiver insisted she takes the medicine. Okay, that's C. That has an impact on B, the behavior. The behavior is the resident continued to refuse. And she continued to get upset. Okay, the behavior is worsening. Okay, the bottom line of the ABCs is we want people to recognize the behavior can be affected by activators and consequences, all right? And what we're trying to train caregivers to recognize is they have a place and an impact on the behavior, okay? To make it better or worse, okay? So in the STAR training, as you can see here, what we would do is, see, I got these little star cards right here that we would use when we were training caregivers. So the first page is we would identify the problem behavior. Here's another example. If we have a behavior where the resident comes up and says, I'm going home. The patient said, it's just as I said, let's go to the person who kind of has a sundowning quality of behavior. She wants to go home. It's 7 p.m. She says, I'm going home. I got to get back to my house. All right. And then the caregiver, her daughter says, Mom, you've been living here for 3 years. This is your home. This isn't my home. Mom, it's your home. No, it's not. Okay. And this causes her to escalate. Okay. This is the essence of the problem. What's the problem behavior? We say, well, mom's being difficult. Mom's being stubborn. Mom's being manipulative. I hear it all. Okay. Those aren't behaviors. Those are inferences. Those are judgmental. What is the behavior that you want to stop from happening? I mean, asking questions is part of dementia, if you ask me, but the problem behavior is the mom is getting upset. She is getting loud. She's getting angry. and trying to get out the front door, right? So the behavior is she is exit seeking unsafely. It's dark out. She's trying to go outside in the dark to go find her house, and that's a bad, unsafe idea. And you want mom to stay in the house, okay? Well, break it down. Mom's trying to leave. What triggered this? What activated it? Okay? The activator is, we don't really know. All we know is she could have been sitting on her couch. Maybe she saw a commercial that reminded her of home. We don't know. But a lot of times you may not know. But we want to say, we're not really sure what happened. She's upset trying to get out the door. Well, she's going out the front door because she's going to find her home. Her daughter says, Mom, you can't go. You are home. This isn't my home. All right. So now the resident's arguing before, we're worried she's going to exit. When she's trying to open and get out the door, the consequence is where once again, the caregiver comes in and has an impact on the behavior. She's going out the door. Mom, you live here. No, I don't. Yes, I do. Excuse me. No, Mom, you live here. No, I don't. Mom, yes, you do. No, I don't. They're arguing. You can imagine this escalating and this becoming an agitated situation. And we want the caregiver and the family to recognize is they have an impact on making this behavior better or worse, okay? Just like this behavior, maybe we can't do much to change it. Mom is trying to get out the door, but how can we prevent this from happening? How can we identify a plan to address this? Now, that's exactly what we try to do. When we identify, well, mom's trying to leave, we're telling her she's home, and that's getting her upset. That's part of the problem, right? The problem behavior on the left, once again, is exit seeking, demanding to leave. What happened? What did the caregiver do? Said, this is your home. She said, no, it's not. And this is making it worse. Okay. So then when we turn the card over, we're trying to get people to come up with a new plan. What is the goal behavior now? What is the behavior we want to change? Well, I don't want mom exit seeking. When she is going out towards the door, we want her to stop. So mom's trying to go out the door. What are we going to do? We're going to activate better behavior. We want her to stay in the house. Our goal behavior is mom stays in the house. How can I activate that behavior? Well, when mom says she's going out the house, we say, Mom, hey mom, where are you going? She says, I'm going out the door. I'm going to go to my house. Like, well, mom, totally. But it's dark out right now and the buses aren't running. Let's wait till tomorrow. We'll totally go visit your house. But why don't you stay here for the night? I want to go now. I know, Mom, I know you're worried about the plants. I watered them the other day, and we'll check on them again tomorrow. In the meantime, Mom, this is let's see what's on TV. Oh, Brady Bunch is on. We're distracting. Okay. So what I'm talking about is come up with a plan. Okay. Now, there's a couple things I've talked about here. I've demonstrated that's part of solutions for dealing with problem behaviors. So ABCs involving teaching caregivers to identify problem behaviors, what triggers it, and how to change the triggers, right? What are our interventions? Our interventions involve two other things, communication and pleasant events, okay? On the handout, I have some information about emphasizing communication, all right? Basically, this is not common sense because I think of it as kind of common sense, but it never plays itself out, meaning how do you talk to somebody who has dementia? How do you talk in a manner that they can understand? We already know that people with dementia are struggling with memory problems and attention, executive functioning. Then on top of it, they are hard of hearing. There's some perceptual issues, hard of hearing, maybe communicating. So there's enough issues happening already. We have to slow things down. On the handout, we want to be able to provide cues for emphasizing nonverbal communication. So we spend an hour talking about effective communication. There is this approach, though, listen with respect, comfort, redirect. It's a hallmark, it's a building block, it's a key tool that I train caregivers to recognize for how to implement change, positive change with a resident. That will be using an approach, listen with respect, comfort, redirect, okay? Back to the example. When mom is saying, I'm going home, we want to be able to communicate and use an intervention that's going to help redirect her, okay? But you can't just say, stop talking, mom, let's watch Brady Bunch, okay? That's not going to work because she has her mindset on this. We're going to use communication. We're going to use good nonverbals. We're going to look at her in the face. We're going to use body position, get her attention, say, hey, mom, you want to get her attention. And this is what they talk about when you look up the communication strategies. We want to pay attention to the resident's emotion and their feeling. Now, I always see that written in books, but what does that mean? Okay, it means the resident is saying, I want to go home. Well, she has dementia, she's confused, and she wants to go home. She feels out of place, and she doesn't know kind of where she's at. She wants to go home. Let's address that feeling, meaning, I'm feeling, so mom, you're in a safe place. You're free to stay here. This is my house, but I would love it if you stayed the night, mom. And tomorrow we can go check out your house. Do you see? We're providing comfort with our words, with reassurance and safety information to reassure, okay? Another common problem behavior for somebody with dementia. I can't find my watch. You've stolen my watch. You stole my money. You stole my favorite. The staff here, they stole my remote control. It's like, yes. Do you think they're going to come back for the television afterwards? You know, so, you know, you can't really just say, come on, it's here somewhere. Nobody stole anything. That usually doesn't work. The thing is, they can't find something. They're upset and they don't know what's going on. I always tell, when I do these trainings at assisted livings, I say, hey, you know what? Your residents are waking up every morning. The residents with dementia are waking up every morning in what they figure is a hotel room, and the housekeeper in the hotel is trying to take off her clothes and change them, okay? It's very confusing if they're not oriented to what's going on. They need to be reoriented and reassured, okay? And that just means giving them the reassurance they're in a safe place. When the person says, they're stealing from me, you're stealing from me, well, they don't remember where their things are, and they're afraid and scared and worried. So when people say they're stealing, the answer is usually something that, oh, that wants reassurance. That sounds terrible. We don't want to argue with them. The argument is, it's not stolen. Yes, it is. No, it's not. That's arguing. Okay. So instead we'll say, oh, that sounds scary. Wow. Your watch is missing. Let me help you find it. Okay. Let's go find it. I want to help you. Okay. So in other words, you're going to use some key phrases that provide reassurance. I want to help you. I want to help you fix this problem. Let me help you. Okay. That's reassuring. Okay. Provide the reassurance. Mom, this is you're welcome to stay here. Reassuring. This is a safe place. Provide the reassurance. Now redirect. Get them walking, then redirect. Oh, okay. After I reassured her about the house, let's watch TV. After I reassured her about, I'm going to help her find something stolen, I might bring up, oh, look, let's go back to your room and look for it. And as we walk, I look for some distraction, okay? So this is the basics of behavior management. We're trying to use this implemented, improving our communication, help reassure the resident. I always use the example of, we are trying to land a big jumbo jet plane. All right. And the resident doesn't know where the runway is. It's cloudy. We're just lining it up. We're saying right here, everyone. Where am I? Where am I? You're in a safe place. You're safe here. People are here to help you. I'd like to get you a cup of tea. What's your favorite flavor? Is it chamomile? Right? That's how we redirect. Okay. We're directing it and okay. Now, and the other concept I implement is the concept of pleasant events, all right? So we can talk about all the ABCs we want, okay? We can talk about problem solving and communication, but we have to do something that makes the resident want to do, the patient who has memory problems to kind of go along with things. There has to be something that makes it attractive. Now, having said that, that is a pleasant event, all right? So what is a pleasant event? Pleasant event is any positive interaction, all right? And what the reason it's come about as a term is people with dementia don't know how to cheer themselves up. They do not know how to distract themselves when they feel poorly, okay? I always do this training with caregivers. I say, hey, you just had your worst day. You got chewed out by a boss, a resident threw water in your face and laughed at you, and you couldn't do anything about it, and now you're upset. You're driving home after the worst day of work. What are you gonna do to make yourself feel better, right? And I ask different caregivers. They say, I'll listen to music. Yeah. I'll call my spouse. Right. I'll call my mom. I'll talk to her. I'll go for a walk. I'll go to the gym. I'll eat some pizza. I'll drink. Okay. Whatever you do to cope, good for you. The thing is, people with dementia don't have the wherewithal to say, I'm feeling bored and alone sometimes. I'm feeling lonely. I'm feeling bored. They don't know what to do. So it takes the caregiver to implement this, okay? So for example, it could be when we go back to ABCs, once again, we're going back to that same example, the woman that says, I wanna go home. What could be a trigger? Possibly nothing. Nothing is often boredom, okay? Boredom is often a trigger for agitation, okay? So we go back to the ABCs, behavior, demanding to go home. What was happening before that? Nothing. She was sitting on the couch. Well, how long was she sitting on the couch? How long was that person alone in the room before they demanded to go home? They need to be roped into doing something before they get agitated and bored, and then getting restless but not knowing what to do. All right. So, problem behavior, demanding to leave. Trigger, not doing anything, boredom possibly. Consequence, well, how are we going to address this with a get active plan? Well, we're going to change the behavior. She's demanding to leave. We say, oh, this is a safe place, but hey, I'd like to join you for a walk. I'd like you to where are those pictures? Can you show me those pictures of your granddaughter? Do something to distract, get them walking, come on out of your room. Let's go get something out of the kitchen, something to distract them, and an activity that can be pleasant. Okay. So part of what we do is we get caregivers and family members. Dr. Terry, when she implemented pleasant events with training family caregivers with patients with dementia, it was about coming up with a list. What are their favorite activities? What are things? Reading the newspaper, cup of coffee in the morning, favorite book, all the little things that make people smile on their, a compliment, right? Having clean clothes on, having your favorite meal. These are all little pleasant events that help make everything a little bit better, okay? So what we have then is what I've covered are pleasant events, communication, and behavior management. Okay, those are the interventions I want family members to understand. Okay, how do I implement this in practice? Okay, we already talked about the problem behavior. So the way we're going to implement this is looking at this approach that is a standard sort of approach for dealing with the problem behavioral issues related to dementia. It's called the DICE approach. DICE, D-I-C-E. DICE, describe, investigate, create, evaluate. Meaning, we have that problem that chief complained. Mom's trying to get out the front door. She's agitated. She wants to go home. I don't know what to do with her. We brought her into the doctor's office because it's every night. I have to lock the door. She's upset. She takes forever to get to sleep. Can I get a medicine so she'll just go to sleep at night and not be so agitated at night? Okay. That's a problem. All right. So the DICE approach is a way for you as a provider, the expert, trying to get an understanding of what's going on because, oh my goodness, it is not easy in a 15-minute provider office to try to get to the bottom of this and provide all that education. But we have this approach, okay? So the first thing we want to do is describe. We need to know what was the story here, because remember, we don't know the story. If the daughter's coming in to tell you, mom is agitated at night, trying to leave the house unsafely. Well, we ask her, what's the problem? Well, she's trying to leave the house. Okay, describe. The first step is ask the caregiver to play back the neuropsych symptoms, NPS. Describe it to me as if it were in a movie. Okay, so well, mom's always upset at night. Okay, that's a bad movie. That's not how you describe a movie. Clearly, you've never pitched a screenplay for MGM. All right, so once again, describe it to me. It's a movie. Okay. Well, last night, 7 o'clock. I mean, I'm just in the kitchen, and my mom starts, like I hear her pulling on the door. I lock the door, and I go, Mom, where are you going? And she says, I'm going home. I told her, Mom, you're home already. Just sit down. And she won't sit down. She keeps telling me, I want to go home. And I said, this is your, then she started talking about how she needs to get back to her home in California. She has to water the plants and all this. I mean, she does this all the time. And, I know she's mad that I moved her up here, and she's mad that I moved her, but this is the only thing that can be done because she couldn't live alone. He's like, yes, I understand. Okay. So in other words, you got them to describe the situation. You understand how they played out. And of course, in this situation, you want to ask the caregiver, well, tell me, what do you think happened, right? And get this whole story, all right? You want to get the caregiver perspective. She's upset. She's a little frustrated. She thinks mom's getting back at her because she moved her up from California, right? Well, what else was going on? What was happening? We're trying to figure out where was mom coming from before she came in the kitchen, started yelling at you, right? Now, we're medical providers. We're also trying to determine what else is part of this picture. Is there any physical pain? Is there anything medical going on? We're trying to get the whole picture on describing this situation, right? So, what's another example? Like, for example, I had the person who crying at night, right? Here it is. She's crying. Well, lay out a picture. What happened? This is the problem that I heard described to me. Well, what happened? You're telling me that the patient was not sleeping. She was crying. She was upset at night. What happened? And then I find out, I talk to the caregiver, and the caregiver at the assisted living tells me, well, she calls her son every night, and she told the son, well, and then I got the son on the phone. Well, what happened? The son tells me, well, she told me, she called me at 8 o'clock and said, tomorrow she wants to go visit her mom. And I told her, Mom, don't you know, Mom, your mom is, grandma's dead. We went to her funeral 18 years ago, Mom. Don't you remember? No, she's alive. Mom, we went to the funeral. This sounds like basic 101 dementia, but this family members could just be that, could be saying this, that triggers. Now, obviously, we put out the ABCs. What's the problem behavior? Resident upset. She's not sleeping at night, right? Why is she not sleeping? Well, it's obviously triggered when she called her son. Son tells her that mom is dead. She's arguing she's not. She's distraught. She can't sleep at night, right? So this whole problem came from a bad phone call, right? And the consequence of the bad phone call is mom continues to be upset, right? So all of a sudden, we have the situation described to us. We got the family member to tell us, yeah, I told her that because, that's what happened. Now, one problem is often also when you're working with caregivers is this seems straightforward. It is not straightforward. How to identify the target behavior, how to be really clear and specific identifying behaviors. You want to be able to pin this down because when you are writing your plan for treating this, you have to identify what are we trying to treat. Are we trying to treat that she doesn't remember, she's in denial? No, we're trying to treat the fact that she's yelling, raising her voice, and trying to leave the house unsafely, all right? That is the behavior we're worried about. Okay, so we don't want to say she's trying to be manipulative. She's in denial about her disease. I've heard it all. She's arguing all the time. Well, all the time, did she wake up arguing? No, it only happens. When does it happen? You want to get specific, all right? So in other words, good examples of target behaviors are specific. He refused to get dressed. She won't take her medicine. She cries in the evening. He wants to go home and tries to leave at night, right? Specific behaviors. Barbara, do I have till 15 after the hour? And then questions till 5:30, is that right? Okay, good deal. So while I'm dealing, so described, I'm then as the provider, I need to investigate what are some possible causes of the problem behavior, right? Clearly, I already have these two pinned down as being issues related to communication and how we're communicating to the patient and how we're approaching them in ABCs. But it could be all sorts of other things that we as a medical provider have to rule out. Is this a result of medications? Is this a result of possibly an electrolyte imbalance, dehydration? Is this due to poor sleep hygiene? What's the sleep like? What are some issues? Is it related to, I want to tease out all these issues. What could be also affecting this, right? You're often wondering, is this, let's play it back. Let's look at the other classic example. They bring, a daughter brings mom in, she's depressed. Oh, okay. What the problem behavior is she's depressed, okay? Well, describe it to me. How is she depressed? Well, she just doesn't do it. Okay, I want you to describe to me all the evidence you have that mom is depressed. Well, mom used to care about gardening. She was a master gardener. Now she doesn't even want to do any gardening. I say, I walk her outside, she comes right back in and sits on the couch. Okay, what else indicates that she's depressed? Is she crying? In other words, do a depression inventory, do an investigation. Is she depressed? Has she lost interest in activity? Well, she says she's lost interest in gardening. What about other things? Well, she used to be such a walker. Now she doesn't want to do any walking. I tried to take her outside. I say, Mom, let's go for a walk. And she says, no. Okay, she doesn't want to do anything. She's depressed, all right? Well, is she crying at all? No. Is she enjoying some things? Do you ever get her to laugh? Oh yeah, she's always, she can, she laughs when we watch, Ellen. She'll chuckle along with that. All right, so in other words, I want to get a good impression. Has she lost interest? Is she not enjoying things? Well, it seems like she can still laugh and enjoy things. What are some things? So what I'm trying to pin down is there some medical reason, right, for her not want to do anything? Is she sleeping all day and night? No. Okay, so she's not overly lethargic or sleepy all the time, right? So in other words, investigate all that, right? Investigate all the possible causes that are going on, right? Now, with that very case of the patient who doesn't want to do anything, because I got referred the very patient who's like, she doesn't want to do anything. She doesn't want to garden anymore. She doesn't want to go walking. She was such a walker. But then when I talked to her at the adult day health, the patient is chatty. She likes interacting with other patients, and she's active around the room. The thing is, she's just not doing the same activities she used to, okay? And the other part of that whole, is she depressed? See, my investigation is, as I investigate, I don't think she's depressed, okay? But I want to investigate other things. I'm investigating, well, she's saying no to these activities. Are there things that she will say yes to? And then in our communication, we know people with dementia, you don't ask them, do you want to go for a drive? Because they can say no. We always want to not get them the option to say no. We say, hey, Mom, time for the drive. It's beautiful outside, and at the end, we are totally going to get your favorite ice cream. That is going to be great. It is beautiful out. Let's go, Mom. I got your shoes. Let's go, right? That is how you get people to do things, right? We don't say, often, we had a patient in the assisted living. She would never agree to come down to eat if you told her it was lunch, okay? But the caregivers recognize all you have to do is say, hey, let's go check your mail, all right? So in other words, it wasn't that she wasn't hungry and she was depressed. She just needed to be told something to get her moving out the door, okay? So those are some of the ways to deal with the apathy, right? That's a neuropsych symptom of dementia, the person that doesn't want to do anything, okay? So I have this as a handout, right? This is in the handout. These are 2 pages in the handout I have with dealing with problem behavior. So the basic story is just like that. I identify with the problem behaviors. What are the activators? Is it boredom, a situation, pain? Down below, I have an example of problem behavior, restless, pacing, looking anxious. The activator is can't find the bathroom. That makes sense, right? And then the other one, we identified. So this is part of collaborating to create and implement a new treatment. So DICE, describe, I, investigate, create, C, create a plan, okay? Collaborate to create and implement a plan. So we have the patient that doesn't want to do anything, okay? We're gonna use, when we talk about the ABCs, right now, you know, I tell you, when I try to implement the ABCs in the primary care 15-minute appointment, sometimes I just can't get to the whole story of the consequences at times. And if you have the time to do it, good. But sometimes in that 15 minutes, all I have time is to get that person to identify the resident's behavior and that you can activate their behavior. So I want the patient to do more. I want the patient with dementia to do activities. So, Mom, do you want to go for a walk? No. Okay, how can I get Mom to go for a walk? What's a different way you can do that? All right, get Mom outside for a walk. Basically, we say, what's a different approach you can use with your mom? Say, well, I don't know. I say, could you try it this way? Could you say, oh, it's beautiful outside. Oh, I just really want to show you I just have to show you what's out in the garden. Here, quickly, put on your shoes. Let's go outside just for a minute. Just for a minute. Okay. And by the time you get her walking, get there, get the car keys, she's already out the door. And then you say, I have to go quickly out. Could you do me a favor, Mom? Why don't you hop in the car with me and I'll run us down to the drugstore. I need to pick you up some of your medicines. Okay. So in other words, we got her out of the house. Okay. That was kind of the goal, the patient that doesn't want to do anything. Right. So what we're doing is we're trying to get the caregiver to understand triggers, activators, to make the behavior better. In this example, I'm identifying a problem behavior. The patient refuses to take their medicines, all right? On the right-hand side, the problem behavior, refuses to take the medicines. Activator, telling him he has to take his medicines. The classic example, we have videos made about this. Ned, you have to take your medicines. You need to take your medicines. I don't want to take my medicines. Ned, you need to take your medicines. I don't want to take those medicines, right? This is a problem. Refusing the medicines. How can we do it differently, people? Using different communication, pleasant events. Okay, we want them to take the medicine, activate it. How can we sit down next to them, have a conversation, then just say, oh, by the way, Ned, I got your medicines right here. I don't like taking medicines. Okay, how can we get this going? Well, I brought your favorite juice. I tell you, you had a stroke once. I don't want you having a stroke again, Ned. I'm worried about you. Come on, Ned. Hey, look, I got your cranberry. Oh, okay, fine. Okay, in other words, find a different way to do it with communication and problem solving, right? So come up with a plan. Whatever your plan is, can we create a plan with the caregiver to address this issue, right? And then identify what the problem behavior is. What is the target behavior? So this is the process where you strategize with the caregiver on ways to fix this problem. And then whether you're implementing a plan that involves medicines or not, identify and chart the target behaviors. For example, in the example, the patient was brought in with concerns of depression. I, as the provider, do not think she's depressed. I think that the caregiver just needs to change the way they're bringing in the opportunities for approaches, changing their mindset about what mom wants to do and can do, and get them going on these things. Okay, so I'm laying out that plan. I say the target behavior does more physical activity. Okay, and the plan that we're going to do is we're going to activate that by scaling it back. We're not going to look for complicated gardening activity. We're just going to get mom to sit outside and have a cup of tea or have some iced tea with you outside. Okay, something to break up the day. Get her going on a walk, get her outside. Once you drove to the drugstore, maybe we stop at the park. Find her a way to get moving, okay? So these are strategies, okay? How about how about the issue we described earlier about the person that thinks the daughter is trying to kill her, trying to poison her? Well, I'll tell you, at that assisted living, what we said is the daughter should not visit anymore. Very obvious to us is the daughter shouldn't visit anymore. I mean, before I sat to look at the antipsychotics, then after the daughter stopped visiting, the patient said, well, they put her in jail. Oh, okay. Well, that sounds fine. All right. Well, you're safe now. Oh, yeah, she's in jail, and I said, yep, okay. So, we're going to go about our business. If she wants to think her daughter's in jail, as long as she's calm, happy, and going to activities, and she's like, this will come around. She's not going to be believing this forever, but we're just trying to make do with the situation, okay? What to do about the person that's a common thing. You might have the chief complaint. She's hallucinating. Well, tell me what's going on. She is hearing voices. Well, she's talking to her deceased mom and dad and her brother. She keeps on talking to them in her room. And this is the basic thing that I always talk to. It's like, well, is it stressing her out? Is it making her nervous? No, but it does. She's just talking all night to him sometimes. Well, she sounds like she's having fun with it. Yeah, I mean, she likes it, I think. Well, it's okay. Sometimes they need to hear from the medical provider. It's okay if she's talking and talking to deceased relatives. If she's in a good mood and doing all right, this is nothing to get worked up about. However, this might turn distressing, so we want to be ready for it. So when in case, does mom ever say like, well, my mom's mad at me, my mom's telling me I'm no good, I'm really feeling bad. It's like, well, I tell you, you're doing it, then we're going to have to change our communication and how we deal with it, right? The person that's hallucinating might come up, these might become stressful and triggers for paranoia, right? Not feeling safe. But other problem behaviors. We come up with a plan for the person that, like as we described, the person that says that they're going out the front door. Okay, it's 6 or 7 p.m. We're going to first address this by looking at the behaviors beforehand. If we identify boredom as a trigger, we're going to change the boredom. We're going to keep her busy at 4 p.m., 5 p.m., and see how busy she can be. And then we're going to find out if this is always happening around 6 or 7, after she's busy, we're spending more time with her. When she starts saying it's time to go, what are some key phrases that we're going to use? Like we talked about, the implementation of communication. Mom, I know you want to go home. As you said, yes, you're home. You're worried about the plants, but the plants are well watered, and I will get you there tomorrow. All right. But for right now, it's dark out. Please, I've had a long day, but I'll get you there tomorrow. All right. And your mom is going to forget. She always forgets these things, and we'll deal with that tomorrow, and she probably will forget. Right. So we came up with a plan. All right. For dealing with exit seeking, how we're going to address this with communication. Okay. Right. Evaluate. Obviously we're going to come back in. After you come up with a plan, it's they came in with behavioral issues. Are they going to give you a phone call? Are they going to come back in a month to 2 weeks to let you know how it's going? Was the behavior plan effective? If not, what happened? All right. And if you implemented a medication, was it working? Right. At the same time, you're dealing with all these problem behaviors. Okay. Back to, I mentioned medicines, and I'm going back to DICE, okay? The DICE approaches we have up here: describe, investigate, create, evaluate. We described we made the caregiver describe the situation. We investigated what could be issues going on. We came up with a treatment plan. We created and collaborated to create a plan. On that time, we're trying to determine, investigate, create, evaluate. Consideration of psychotropic drugs, right? We're trying to determine, let's say this person is anxious and exit seeking. Do we want to prescribe a medicine to help her with that agitation at night? How bad is her going? It is unsafe. We are having to make a decision. Is a medication need to be used here? Because I can imagine situations that it's very dangerous if she's getting out the front door and the cops have been called 3 times, mom has wandered off 3 times, and it's taken us a couple hours to find her. That's not safe, okay? She might lose her ability to live independently in her house if this is occurring, right? And maybe we will try a medicine to calm her down so she's not so agitated at night. That is one of those things that when it comes to medications, should we try a medicine? Now, I'm going to spend a little time talking about how effective medicines are and how we implement them along with our approach. The bottom line is, as I go back to the DICE approach, we could be considering the use of the psychotropic medicines anytime along this way as we create our treatment plan. Okay, and we are considering it. Of course, even if we're using the medicine, we are still problem solving around this. There's no clear answer. If it depends, every situation has its own nuance. All right, and the truth is, every medicine has its own side effect potential. How effective are they going to be? All right, so I do want to say when it comes to how effective are medications? Here, the short answer is not that effective, okay? So first off, medication-wise, all right? There are various classes of medicines. There are antidepressants. So when it comes to psychotropic medicines, and me as a psychiatric provider, these are what's in my toolbox. Antidepressants, antipsychotics, mood stabilizers, the memory medications, those are the cholinesterase inhibitors like Aricept or donepezil, rivastigmine, that's Exelon, and then Namenda, Memantine, okay? And then the benzodiazepines, the Xanaxes, lorazepams, alprazolams, Zolpidem or Ambien at night for sleep, right? These are medicines we may consider using, okay? They all, I'm going to quickly review a little bit about their efficacy, but there's also obviously the safety issues. So short answer, overall, antipsychotics or antidepressants, they're generally less effective than the treatments of the medicines they were developed to treat, okay? What I mean by that is step back and think about the antidepressants, Prozac, Zoloft, sertraline or fluoxetine. Who were this developed for? These medicines were developed to treat depression in people that were not demented. These medicines were developed for people who suffer from major depressive disorder, probably a recurrent chronic depressive disorder, right? Which is typified by depressive episodes over the course of a lifetime, right? That's what the medicine's there to treat. We are basically giving that medicine to patients with dementia, hoping that this will reduce their depression and anxiety, for example. And once again, antidepressants, of course, are also the drug of choice for generalized anxiety disorder, panic attacks, post-traumatic stress disorder, OCD, okay, right? Those are anxiety disorders. They're the drug of choice. But will they work for dementia-related anxiety? It's, at the least, they're not as effective as they would be if they did not have dementia, okay? Then on top of it, and then when it comes to antipsychotics, antipsychotics were developed for people treating schizophrenia, right? It's dopamine blockers. We're trying to block dopamine, but that's not the condition. We're not trying to block dopamine related to dementia because we know that there's neurobiological atrophy of the brain. We have brain damage. Why would an antipsychotic medicine, there is no clear mechanism of action on why that would be helpful. It can be helpful, but I just want you guys to know that it is generally that it's not that effective, and you want to use them judiciously. Because here, number two, when they did a chart review, this is 2018, this study by Trinkley, when treated with an antipsychotic, more than half had worsening of behaviors, while a third had improvement, okay? In this, to skip ahead, how effective are antidepressants for dementia-related depression? This is a great study. And this highlights, as somebody that treats people, older adults, for psychiatric issues with dementia and without dementia, when older adults who are just depressed but don't have dementia, antidepressants are less effective for them than they are for regular age adults. And the placebo response is more potent, meaning regular age adults might have, okay, if I had bar graphs describing how effective antidepressants are for 40-year-old people, they would work on a bar graph 66% of the time. The placebo would be 33% of the time. So a 40-year-old with depression, how effective are antidepressants? 66 are working for depression, 33 is a placebo response. For older adults, that 80-year-old with depression, it goes like this. This part means no longer are they 65% effective, they're now 55% effective. And the placebo response goes from 33% to 45%. And hence, when we have drug studies, they don't separate from placebo. Okay? So, and then when it came, there was one study from like 2000 using sertraline or Zoloft for dementia-related depression, and it showed efficacy. Then this study came out in 2011, Banerjee out of London, and this in the Lancet out of England. And it was a huge study. You had 111 controls and 107 participants determining how effective are antidepressants for dementia-related depressive symptoms, meaning they look depressed. They're sad. They don't want to do anything, flat affect, crying. They look depressed, these people with dementia. Does an antidepressant work? Look at the results here. At 13 weeks, okay, this is going to take some critical thinking, but I'm just going to describe to you. Look at it. There's 3 lines. Placebo, obviously, you double-blind it. You have people enrolled in the study. They are residents in long-term care or in the community. So they really don't know they're in the study, okay? They don't know they're in the study. They got randomized whether they're going to get sertraline, mirtazapine, which is Remeron, or placebo. At 13 weeks, they all showed drops in their depression scores. And at 39, they did not separate from placebo, okay? There's 2 ways to look at this, okay? One way is saying the antidepressants don't work because they don't separate from placebo. And that is very much what it says. But I also want to point out at 13 weeks, everyone's depression scores went down. Why did everybody's depression score go down? My hypothesis is simply this. Everyone that's enrolled in a study gets better. Most people get better in a study because they were involved in the study. Being in a study is its own intervention. It involves you being around the patient with dementia more. You're asking them questions, you're visiting with them more in order to get the determination if they're depressed or not. And this is the same reason there's a potent placebo response with older adults who are not demented. Increased activity, increased socialization, reduces depression. So you get enrolled in the dementia study, people are going to be generally more interested. This is a take-home message why pleasant events and keeping people physically and socially active will reduce their depression scores, with or without antidepressants. But so what I'm getting at is the antidepressants may or may not be working. And if you want to do an antidepressant, why not put the interventions in to do non-pharmacological interventions first before you think about doing the antidepressant? Now, but generally, that's not often why people are coming in. Usually I am seeing the highly anxious, paranoid patient, all right? I mean, I've had patients that I definitely use antipsychotics for, okay? Patients who are, like this one woman I just treated over the last 2 months. I mean, she was at the assisted living. First, she would not get out of bed. She was peeing all over herself, or biting, kicking, punching, spitting when they're trying to provide care, and then she wouldn't come out of her room all day. And when they did get her out of her room, she was crying constantly. And Lordy Lou, 5 milligrams of I called the family. I said 5 milligrams of olanzapine. This is where we're going to start. I imagine that we're going to get it up to 2.5 and then 5. But I just know that I'm going to have to add Depakote to this. I'm going to have to throw the box. These behaviors are so terrible, and I know I'm going to have to use 2 medicines to relieve this distress. But I cannot believe I just put her on 5 milligrams of olanzapine, and this patient, after 3 or 4 weeks, she's calm, she's cooperative with cares, and she's up at 9 or 10 in the morning. She's willing to come out of her room. She's generally calm and cooperative and has an obvious improved quality of life. Before, she was highly distressed. She was sitting in wet garments because people were getting bruised when they were carrying, and this medicine turned it around, okay? That's one of the successes, okay? But for as many of those successes, I also see, oh, they're agitated punching. Well, now I gave him olanzapine. He's incontinent a lot more. I mean, they're just incontinent more. He's not before he was able to signal himself or gasp for help and go to bed, now he just pees or has bowel movements right then and there, right? Increased confusion, okay? More severe. Those are the side effects that sometimes occur, right? And then on top of it, there are safety issues with these medicines, right? I mean, the big Katie study indicated that medicines, they have safety issues. The big, these medicines have a black box warning on them that say they can be dangerous for people with dementia, all right, right? There's a higher rate of death. So as I described to family members, if you're over 80, you have a 2% risk of sudden death and stroke over the next 6 months. 2% risk. And if you're on an antipsychotic, that risk goes up to 3.5%. That's 1.5 times more likely. But make an informed decision is what we want the family to do. Do we want her screaming, biting, and crying all the time, right? I mean, I have residents who were just so afraid, right? The patient that is convinced people are trying to kill her. And this is, I mean, she is in absolute distress. I mean, so she's not a danger to herself or others, but her fear is palpable. And I want to relieve that distress. And so I might consider one of these antipsychotics, but that consideration is done by an informed, durable power of attorney or the patient making a decision if they want to try this medicine and deal with the risks, right? And then I often say, look, let's give this 3 weeks and see if there's less distress, less worry, and if this person, now, this is the take home. When it comes to an antipsychotic, I was just recommending an antipsychotic for a patient, and they said, well, and the family says, well, this will make her, I said, so when I talk to her, she'll understand when I say she can't go back home. She'll understand reality. I said, whoa, no. This medicine does not make anybody understand reality, okay? I'm saying is when she demands to go to California, that we can say, oh, absolutely, tell me about your home. Oh, okay, well, in other words, we're doing the same thing. We're going to try to reassure her that she's safe tonight, and can she wait till tomorrow? That's all we're trying to get happening. So we're trying to get the medicines to make the behavioral interventions effective. Bottom line, when I'm trying to distract, reassure, and trying to use listen with respect, comfort, redirect, and if that is making a patient angrier and more upset, well, yeah, I think I probably do need to try medicine, because the basic communication and basic problem solving is making this worse. They're a safety risk. They're punching and hitting other people. This is their housing is in jeopardy, and they're at risk for ending up in geropsych. Listen, my whole quality of life issue is keeping people out of geropsych. If I can prevent a psychiatric hospitalization, if I am preventing a lot of undue distress, and it can be described as traumatic, to take a demented person, strap them on a gurney, take them to the emergency room, and have them go through that bizarre, changes of settings, providers, and all that goes involved with trying to keep somebody safe. Can I keep them safe in their own house? That's what I want to do. But on here, I have a description of, there's all these, what did I have on here? These are number of patients who receive treatment that would be associated with one death, right? So on this list, numbers needed to harm. 26 people with Haldol is generally associated with one person dying. Or in this study, this was done with VA patients, published in 2015. These VA patients, when they did a chart review, they saw that the number needed for death for quetiapine was 50, for risperidone was 27, right? So 50 people taking quetiapine is associated with one person dying. For an antidepressant, it's 166, okay? Now, that means there's a big difference in the level of danger. Now, we've all looking for the medicine that works. And I have to say, this is a great article that talked about perception versus evidence. People are always wondering, well, what can we use instead of the antipsychotic? Because the antipsychotic shows some effectiveness. I'm sorry, I didn't show the slide. The slide indicates placebo versus not. These are the 4 antipsychotics: aripiprazole, olanzapine, quetiapine, risperidone. They favor treatment over placebo. So they do show effectiveness. The problem is there are the side effects, risks, okay? And if you're ever using these medicines, I'm going to quickly throw out some blurbs at you. Often when I'm treating with a risperidone or olanzapine, which are more effective than Seroquel, because geropsychiatrists will tell you Seroquel needs to be 100 milligrams to 150 to actually help with agitation, but people are only stopping at 25 and it's not working. Well, that's because 25 is too small a dose, but if you try to get to 100, sometimes it's too sedating. So try the other ones. But I often see the concerning extrapyramidal symptoms and the increased confused behavior, incontinence. All of a sudden, they can't use a fork. They can't find their room. They were able to do these before, okay? These might occur 3 or 4 weeks later, okay? Not just, so in other words, let it play out for a month. Give it 2 or 3 weeks if you're using an antipsychotic and start low, okay? If you feel like you have to use one, okay? So just be careful and remember, be ready to pull it off. And even if you agree to use one, I just want to say, identify what are the target behaviors you want to treat. Identify when you plan on discontinuing this medicine, okay? We will use this for a short amount of time. Remember, this is dementia. So as the disease progresses, they weren't always paranoid, okay? But now they are, or now they're psychotic, and now they're agitated. Well, they're not going to be like this as the disease progresses. So in 3 or 4 months, we should be able to reduce this medicine, okay? There's a big list of medicines. I just want to indicate on this, perceptions versus evidence. There is no evidence that Depakote works for dementia-related behavior disturbances. And there are also safety risks with this medicine, okay? And I also want to indicate, as I indicated up here, memantine, there is evidence, and it's, in this 2017, look it up, Namenda or memantine helps reduce dementia-related behavior disturbances. And it is ridiculously safe. So I would like people to consider using that medication. It takes a while to get titrated up. So if somebody's prone towards agitation, I often am thinking about that medicine. Antidepressants, citalopram shown to be effective. But if you're going to use these, I just got to emphasize, you're going to be using the behavioral interventions are still the priority with or without pharmacological interventions, okay? And we have to sell it. As providers, we have to emphasize it. That's, I think, where it falls apart. The doctors, nurses, nurse practitioners, we're too focused on we have to talk up how our the patient, the caregivers, what they do will activate the resident's behavior. You have to empower, that's my take home in conclusion. These behaviors work. These interventions can work and they can reduce the severity of behaviors, but we really have to empower the caregivers to try it and get creative and be assertive, and we have to problem solve with them. Okay. That's my time. See if there's any questions.
All right.
Move this. Sorry.
Okay. Trying to get this done here. All right. If you could put your questions in the chat box, I'm hoping you can hear me, and I will convey them to Huda. We do have a question here already that asks if you could explain a bit more about what is simulation presence therapy.
The question is, what is simulation therapy? Gosh, you know what? I honestly cannot give you a great, I looked over that article. I'd encourage you to go to that article. Okay, look up, what's the name again? Ahala. That indicates those behaviors, and please Google it. Look up that article, and you're asking what are the sensory stimulation therapies? Abraha. I can't speak too much to it. I just did a cursory search, so please, I'd encourage you to find out more.
Okay, and what does CBD stand for?
Oh, I put those letters in there, didn't I? Okay. So I had a slide on here that talked about CBD. Okay, the very bottom, know how effective medicines are. We are always short of time. That last bit I said regarding CBD, it is what it sounds like. It's THC, it's CBD. It's the marijuana derivatives that all that people are coming in. Well, can I use CBD for my mom? okay? I would like you to direct your, I would like you to get, you can just go to the New York Times. This was just in December 26, 2018. Just type in CBD, helpful or hype. And there's an excellent article written by a psychiatrist for the New York Times indicating how you never know what is in CBD. So people are going to say, why not use CBD for my mom with anxiety or agitation? Short answer, there's too much to say about this. I don't rule it out as a treatment option, especially for somebody with Parkinson's-related psychosis, because people with Parkinson's react very poorly, or people with Lewy body dementia, or their psychotic, psychiatric symptoms, terrible distress, terrible hallucinations. Medicine don't work. So but I really don't recommend it. Okay.
And what does CBD stand for?
Oh gosh, what is CBD?
Some technical name?
No, it's just like THC. It's just the other version of marijuana that is in the recreational marijuana stores and in the dispensaries. It's a lighter marijuana that they think is not as psychoactive. So they're thinking that this is more relaxing, can help with anxiety, but not contribute to the psychotic symptoms or the psychedelic effects, right? But the CBD, when you test it, it has just as much. You don't know if it has THC or the active ingredient. You just don't know what's in it.
So it's cannabinoid, something.
Yes, cannabis. It's a cannabis derivative.
Okay, and here's a question: what to do about repetitive questioning?
The question is, okay, what to do about repetitive questions is the person that says, "What do I do now? Where do I go? What do I do?" Well, the context is, how does it play out? I mean, does the person wake up in the morning and go to bed at night saying, what do I do? What do I do? What do I do? Probably not. There's got to be a period of time when they're asking that question, generally when they're not busy, okay? So I will work with caregivers to talk about how to keep that patient busy and active. And even when they're not asking, what do I do? Just know that they are thinking about asking, what do I do, okay? So you have to, the bottom line, they may not. So there is a level of, what do I do now? Oh, sorry. There is a level of anxiety that may be associated to the repetitive questions that might be one you might want to consider using medicines. But really, repetitive questions without an anxious affect or without worries, just asking, hey, what should I be doing? And then you say, oh, you're doing fine, Brad. We're going to have an activity in 2 minutes. Oh, okay. 10 seconds later, what do I do? Try to keep them busy, try to keep them active, but that's part of the disease. We have to keep that person busy and active. That's about it.
Okay, in progressive dementia, doesn't the brain lose its ability to process medications?
Not really. First, that's an interesting thought, but the medication, first off, no parts of the absorption and metabolism is being affected. It is processing the medicines differently. I would say that, but it doesn't lose its ability to process the medications. For example, a benzodiazepine certainly has an effect. The GABA effect is very obvious with the benzodiazepine with somebody with dementia. It's just a little bit different than it is with somebody non-dementia. Okay, so it's different more than anything.
Okay, sleep disturbance is a big issue for at-home caregivers with dementia. Any suggestions?
Oh yeah, well, sometimes when I visit adult family homes, I see residents kind of just sitting there all morning, and they could be napping during the day. So first question is, are they being as active as possible during the day? Okay, first, having said that, that's us trying to find any little tweak we can do to make it better. But circadian rhythms are disturbed with people with dementia, and it is tough, okay? No matter what you do, a person may actually still just kind of be up at night or only sleep for 2 or 3 hour intervals, then be back up again, okay? I mean, frankly, this is why we have assisted living memory units. So because people can just take those 2 or 3 hour naps, the disease may not let them sleep for extended periods of time, okay? And this is really, really tough. I mean, this is what the disease allows. We're trying to mitigate, okay? So we're going to problem solve this and use as many opportunities to say, we're going to keep them active during the day. We're not going to give them any sedating medicines during the day. We can do things like use white noise machines. We're going to try to, just do whatever we can to get that person to a sleep pattern rhythm and into a routine that promotes sleep, a good sleep-wake cycle. But it's tough. All right. And often I'm seeing that's when people turn to these sedating medicines, because, I mean, at a basic level, it's like, we want to try to keep people at home. And that's why sometimes they end up on a lot of trazodone or even, these other stronger medicines, because, if we can just get them to sleep a little bit longer, we might be able to let that person stay living in their home with their family member another 3 to 5 months, right? That's a real thing. And you'll be asked to prescribe the medicines, and you're having to make this informed decision. But they've already tried everything, and maybe we will still try some trazodone. Okay.
Questions here in the room? Okay, then I think that's it. I don't see any other questions coming across in the chat box.
Okay.
Thank you.
Well, thank you.
That work out okay to be sitting down when you're not feeling so great?